I'm Dr. Jamie Koufman. This is Dr. Koufman's Acid Reflux Hour. Today's topic is understanding acid reflux treatment. Understanding anti-reflux treatment would be a better term. Understanding peptic reflux treatment would be a good term too. There are two types for now of reflux. We have GERD and we have respiratory reflux. Respiratory reflux is a new term, a newer, more comprehensive, more accurate, easier to say respiratory reflux for LPR. So LPR is respiratory reflux and respiratory reflux is LPR. GERD is heartburn, indigestion, and esophageal disease, and it is the domain of the gastroenterologist. It's very interesting. We received proof that gastroenterologists know nothing about respiratory reflux this year. I'm holding in my hand, sorry, an article, The San Diego Consensus for Laryngopharyngeal Reflux and Laryngopharyngeal Reflux Disease. And this is a bunch of gastroenterologists, speech pathologists, and psychologists getting together and telling us what they know. For example, one of the statements is you can't tell reflux by examination of the throat. Well, that's how it should be diagnosed, by examination of the throat. None of their tests are worthwhile. In fact, Candace, first question, I had every test until under the sun. Everything came back normal until I did a barium swallow, and I was able to. So right now, for respiratory reflux, probable barium swallow is the only test that's worthwhile, and it can be normal even if you have respiratory reflux. So I don't want to spend too much time, but I just want to make one other comment about diagnosis, which is very interesting. If you say heartburn and describe it, diagnosis, GERD. If you say, I don't know, thick postnasal drip, hoarseness, globus, and shortness of breath, which you describe as a difficulty taking a full breath in, the diagnosis is respiratory reflux. And there's a whole bunch of symptoms. By the way, people who have respiratory reflux, I can't remember the number for sure. It was either 5.2 or 6.2 symptoms. So there's a very clean, I'll say constellation or constellations or clusters of symptoms that, in my opinion, make the diagnosis. For example, if you wake up in the middle of the night coughing and gasping for air like a fish out of water, that's basically a reflux in your larynx with closure of the larynx to protect the lungs, called laryngospasm, and it's a terribly frightening thing. I had it way back when. So anyway, I want to tell you the most important thing. If I were going to talk about one word, you can probably think to yourself, what would it be? Begins with a P, and then an N, pepsin. So getting rid of pepsin is anti-reflux treatment. So getting rid of acid can get rid of it, but for example, in this ridiculous. By the way, I would say when you include arrogance and ignorant together in the same sentence, which these people are, it's a very bad thing to say about physicians. Anyway, I forgot what I was going to say. It's all about pepsin, getting rid of pepsin. So, what do we know about pepsin? We know that pepsin attaches to tissue, it gets in tissue, causes inflammation, stiffness, swelling, and for example, if the lower esophageal sphincter is inflamed in such a way it doesn't work very well as a sphincter. So that's one of the keys to the chronicity of reflux. It's the lower esophageal sphincter. Oh, I know what I was going to say. I forgot. One of the things that this group of experts says is if you put somebody on twice daily proton pump inhibitor for 3 months and they don't get better, they probably don't have a respiratory reflux, or what they call it, LPR. That's ridiculous. PPIs fail in most people. Getting rid of it's good for people with heartburn. That's about it. So the answer to that is wrong. So proton pump inhibitors, by the way, only reduce your acid by about half. So instead of having a ton of acid, you have a half a ton of acid, which is a little better than some other drugs. But it's not. Proton pump inhibitors, you know what they are: Nexium, Prilosec, omeprazole, and so on. They cure 0% of people with respiratory reflux. They probably cure 0% of people. So I want to talk about treatment, but before I do, I want to tell you that it's a chronic disease. So reflux is a chronic disease. The more you reflux, the more swollen, the lower esophageal sphincter is stiff. The more you reflux, esophageal dysmotility can result, and then the more you reflux, the upper esophageal sphincter can go out. You can have globus and dysphagia. By the way, they didn't know what globus and dysphagia were. They're definitely 95% of globus, a sensation of a lump in the throat, or a tension in the throat, or a reflux. By the way, the psychologist, the idea that if you don't know what it is, send them to a psychologist. Ugh. Okay, that's not a good idea. So, but the concept of a chronic disease, well, sure, it's a chronic disease. So, even if you change your diet, it's better. Well, what time do you go to bed? Did you change that? Are you eating the same food every day? That might be a trigger. Are you doing other things? Are you exercising after eating? And there's a million things we could talk about that are risk factors. And changing, people say, oh, I went on this medicine and it helped a lot, or I went on famotidine and it didn't help at all. So I'm going to present and describe a 10-part detox program that I recommend, and it's complicated, and it's nasty. Nobody wants to do this. Furthermore, it asks you probably to make some lifelong changes. The idea that you can get your reflux fixed and go back to just doing what we were doing. I had a consult with a woman that declared she was going to eat chocolate every night before she went to bed, and I said, listen, this consult is not going to go anywhere if you insist upon that. So there's a basic idea that this will add help. This will add help. This will add help. What if I have this procedure? What if I double this medicine? What if I take, licorice? That all these little things are going to help cure this chronic disease. Great diet, eating earlier, no obesity. A lot of things you can start adding as risk factors that you could work on. But again, go back to the question of pepsin. So let me tell you that we know that this pepsin, and I want you to go on my blog, jamiekoufman.com, and I told you this before, I think there's an article on alkaline water with a man that made out of water. And when you go there, you'll see a biopsy, and I know you're not a pathologist, but the first biopsy is regular staining. It shows some inflammation. And then the one to the right of it, all that stuff is very dark. Is a specially developed pepsin immunoassay, so we could detect pepsin. And by the way, it was just a patient with reflux laryngitis with hoarseness, and we don't biopsy the vocal cords. We go behind the postcricoid area, but it's intracellular, extracellular. It's on the surface deep. So getting rid of pepsin, the fastest, in my opinion, you can get rid of pepsin is 3 weeks. So maybe that's wrong. But that's my opinion based upon a little scientific data and clinical data combined. So we call those rapid responders. If someone comes in with a terrible looking larynx and 3 months later it looks pristine, I don't think you're going to find pepsin. So this idea of chronic disease means that small treatments, including surgical treatments, somebody asked me about some new thing with it. I mean, it just sounds awful. Reflux stop. Ugh. Terrible idea. I mean, really. None of these things. Listen, let's talk about GLP-1s. Okay, I think the idea of taking GLP-1s for weight loss is terrible. Okay, I weighed 217 pounds when I was younger. I was a sugar addict, and I've lost the weight. 5'9", 150 pounds roughly for 30 years. So, the trillion-pound elephant in the room is the American diet. So the idea is and if you're smart, you're never going to go back to the same diet. If at lunch every day, you and you guys all get at McDonald's, probably ought to bring your own lunch. So this question of what you need to do to treat reflux is you can always treat a symptom and make it better. By the way, proof that there's chronicity is the Danish study. The Danish study, national study, 10,000 people with esophageal disease. Long-term use of proton pump inhibitors was associated, statistically significant, associated with an increased risk of esophageal cancer. And I went, takes care of the very quiet organ in the esophagus. If they had heartburn and you stopped the heartburn, the disease went on unabated. So in other words, it wasn't a treatment for the disease, it was treatment for symptom. So that's another big, if you will, I would say, a very important piece of data about the chronicity. So now we're dealing with a chronic disease. What do? You got to shut it down. You got to shut it down and and by the way, there's no magic bullet. That's what I like. The magic bullet. I have a bullet I shoot that bullet, my house gets clean. I have a magic bullet. I shoot it, and all my shopping gets done. I have a magic bullet. I shoot and I get skinny. So this idea is very American. The idea there's a magic bullet. Well, there isn't. My complex 10-part reflux program works. It is not for everybody. Because you can't say, well, I can't do that, but I don't like taking that. This tastes bad. I'm not going to use it. So what I'm going to tell you is the reason I want to do this today is how each one works and what it does. So I'm going to go through each of these 10 things, and I'm going to tell you why they're there. And by the way, all of them have been studied. So, for example, I'm going to recommend alginate like Gaviscon Advanced. Goes back to a study we did, 30 years ago. A man with heartburn said, when I take this Gaviscon, my heartburn goes away. So we studied it. It was never published because a man, it was a great study, who was sort of the head of Gaviscon at Reckitt Benckiser left and took another job, and I couldn't. He didn't have like an underling who was interested in this paper, and I couldn't do it. So, but anyway, it makes it, you get better faster, and you get better with alginate. So I'll talk about that in a minute. So, number one, intermittent fasting. So when you say intermittent fasting, people think of, you don't eat any breakfast, you don't eat any lunch, and around 4 o'clock you start eating like a pig or you start eating until bedtime. That particular intermittent fast is called the reflux intermittent fast. That's how you get reflux. Good idea for the refluxer. No. So my intermittent fast is the opposite, and people go horrified. For all intents and purposes, I recommend that people stop eating 7 hours before they go to bed. 7 hours before they lie down. So you go to bed at 10, you're closing the kitchen at 3. You want an empty and quiet stomach. Empty means there's no food, and quiet means there's no acid or pepsin, and it's a quiet organ. You cannot have anything with calories. I recommend for grumbling stomach or hungry chamomile tea or ginger tea. I love ginger tea, but it needs a sweetener. Personally, I use one sweet and low. You cannot use sugar or anything that has calories. It'll start, insulin, glucagon can turn the stomach back on. So now you've got a quiet and empty stomach. 7 hours now this is going to get to the question of, okay, when this is done, how many hours should it be between when I eat and when I go to bed? So for those out, anyone who's listening, including my doctor friends, if you eat at 8 o'clock and go to bed at 10, you have SNOR, supine nocturnal respiratory reflux, and you've had it for a long time. And you got sleep apnea and snoring and a whole bunch of other stuff. So you don't empty your stomach in 2 hours for sure. 3 hours, quiet. So it may end up that I think something between 4 and 5 hours. And I will tell you that I usually eat between 5 and 6 and go to bed usually around midnight or 1. I got lots of hours. So having an empty and quiet stomach, that's a big therapeutic. I mean, that's the complete opposite of going to bed with your ribeye steak and béarnaise sauce on your asparagus dinner, already still in your stomach, already ready for reflux. So this is a big change. Intermittent fasting, and you can just take whatever your average is. Take 7 hours and leave it there. Don't take it, today I'll go to bed earlier, I can eat later. No. Once you make a decision, it's 3 o'clock, it's 5 o'clock, it's done. And it makes it much easier for you, and it makes it much easier to do and plan. So intermittent fasting, nothing in the stomach, no activity. I recommend sleeping on an incline. All of the wedges sold by the GI groups that I've seen like this, putting blocks under the bed, they're like spitting in the ocean. So 45 degrees is gravity. I recommend if you have a bed that goes up and down, that you make some precautions. At 45 degrees, you need a pillow under your body, pillow for lumbar support, one under your ankles. I've gone through this before, and you can do the same thing with a recliner, although it's harder to get it comfortable, and people generally don't like it. But if you take the combination of an empty, quiet stomach and gravity, then you're really, really doing something. Low acid diet, low fat diet, we've studied this, of course. We know from cell biology that injury will occur. We're mostly studying the larynx and pharynx, but we know that injury will occur at pH 5 or less. And as the gastroenterologists think the esophagus at pH 4 or less, when they were starting out doing impedance testing, I know all these people, we're all working together. I said to Don Castle, I pleaded with him, that anything above 4 is non-acid reflux. I said, that's just wrong. Okay, I mean, there's acid activity all the way up to 6 point whatever it is, and the pharynx is 5. So non-acid reflux should be, something above 5. Say 5.5, we'll call it now non-acid reflux, or 5, above 5. So low fat diet. You want to keep the pH under 5 if you can. If you're looking for the diet, it's on my blog, JamieKoufman.com. Just type in a reflux detox diet. Now, meanwhile, I want all of you who say, I've done so much better, I've been on your diet for 3 weeks. Here, what time are you eating? What incline are you sleeping? Remember, we're treating a chronic disease. Okay, it's a big difference than dandelions come up and you go out and get them. Okay, and guess what? Then they come up again and again and again and again and again. So there's got to be another more aggressive treatment to treat those dandelions than plucking up the ones when they show up. And by the way, in terms of chronicity, people have 2 years ago I got a cold and I coughed for almost a year, and then this year I got COVID and I began having terrible problems swallowing, and it goes on and on and on. And the chronic disease is just sort of sitting there waiting to be spiked, and so I think that's how it works. So remember, once we want to eliminate it, and I think if you can eliminate reflux 100% for a month, everything will heal. How do I know that? We've examined people. We've got biopsies. We've done it. So low acid, low fat, nothing out of a bottle or can, only fruits, melons, and banana. You're basically drinking water and some coffee or tea. I recommend 120 milligrams of caffeine or less. 1 cup of coffee, 90. 1 cup of black tea, 80. I drink 2 in the morning. Green tea is 30. A lot of people can get away without any caffeine. So, only fruits, melons, and bananas. And if you get dropping acid, it's on page 46. And if you get Dr. Koufman's Acid Reflux Diet, you don't need the books. It's on page 48. You don't need the books. So if you type in reflux detox diet in the blog, up it'll pop. It's as a post. Now, I don't know how to say this without... A proton pump inhibitor should be removed from the market, in my opinion. They do more harm than good. They have side effects that are tricky, that I've dealt with for a long time. Getting off them, about a third of people have rebound hyperacidity, which is miserable. So someone comes to me and they want my recommendations for treatment. I tell them to stop their PPI and instead, by the way, famotidine is generic Pepsid. Okay, and generic Pepsid famotidine comes 10, 20, and 40. I recommend 20s. 20 milligrams in the morning before you get up, 20 milligrams 30 minutes before your last feeding or dinner, and then most important, 40 milligrams before bed. There was so much nonsense on the internet about famotidine that I went into the medical literature, and there are no side effects. It's easily the best and safest medicine that we have. It's 7 times more potent as an acid reducer than Zantac that we use forever. And if you go to my article, the article OTC, that's over the counter, you can click on Amazon and get it that way. So famotidine is an acid reducer. The 2 at night really help. I'm a big fan of alginates. Alginates are the most popular reflux remedy in the world. They do work for a lot of people as an adjunct or even as a single therapy. They're made out of seaweed, and there are 3 right now. The Reflux Gourmet is the most expensive. Reflux Raft is less expensive. They both taste better than Gaviscon Advance. I like Gaviscon Advance because we studied it. Gaviscon Advance is the only thing you can get. So when you go to your drugstore and you see Gaviscon, that's not Gaviscon. It's actually an antacid. So Gaviscon Advance is you get it. You type on Amazon Gaviscon Advance. And by the way, that's the name of the product. Gaviscon Advance, 500 ml bottles. If you can find them, get 2, and drink it out of the bottle. So one glug, which is a swallow after dinner, and 1 before bed. Now, if you're having rebound, you just stop getting on. Take it after every meal. Okay. So we know that's your medicine. They're both over the counter. Next is alkaline water. Alkaline water should be pH 9.5 or above. Do not get an alkaline water that has phosphate in it. Coca-Cola makes one called Essentia. It's everywhere. Just Coca-Cola. People tell me it burns their throat. I think it's the phosphate. Should be no. People say, I get headaches from alkaline water. You don't. Okay, there are no side effects from water. And it's just water. It just has a different pH, a big range in pH for water, in the world. So anyway, alkaline water causes no harm. I have an article on alkaline water drops. The reason why alkaline water is a good idea is because, and by the way, I want to go back to the diet. You don't want to feed the pepsin. Okay, pepsin does damage at pH 5 or less. You want to give pepsin, and if you're drinking a Coca-Cola, that's a very, very low pH. So understand that we're trying to keep the pH 5 and above for pretty much everything. Alkaline water should be 9.5 or higher, and this is really important. I think this is a thing on Broadway. At the end of the same article, A Man Made Out of Water, you'll see these little blue bottles that are very popular. And I want to tell you, when you swallow, you never get any water, which is high pH, in your larynx. It clamps shut. Most of your throat clamps shut, so you don't aspirate. However, if you put your alkaline water in here, and if I had bronchitis, I'm inhaling it. Pepsin dies at pH 8. Molecule breaks. That can't be reconstituted. So you're spraying with 9.5 or higher, and so that's why that's useful. To my way of thinking, this is the only thing that can hasten recovery for someone who's got voice problems, and voices are very important. So now we've got alkaline water and alkaline water. And by the way, do you have to drink alkaline water everywhere? No, you could go out and drink regular water. Some people get the alkaline water drops. There's an article on them. But, it's fine if you don't drink alkaline water at the restaurant. But careful what you order, though. Comes now a very, very important one, and particularly for someone who might have rebound. I don't know how many of you have been to Carnegie Hall in New York, but they have these vats where you can take Ricola, cough drops, and it's free. And the amount of ambient noise was significant, so we did that. All these people went out to dinner and had a nice, rich meal and wine, and they all have reflux, and they wanted to come to Carnegie Hall and clear their throat and cough. And here's what happens. When you suck on hard candy, you make more saliva, more bicarbonate, you swallow a lot more. We actually studied it this way. We put pH, a probe, we use a pH probe, double probe, in our patients. And we say to the patient, for this study, why don't you go have lunch next door at the Brooklyn Diner and then come on back? And we looked, and so we wait, here's a reflux episode, chew gum, and it went away. Here's another reflux episode, good one, chew gum, went away. So we think that this is a very, very useful. People always ask me what I recommend. I recommend the big old-fashioned Ricolas, and that's what we put in Carnegie Hall. And I also recommend cinnamon, sugarless, only because the other ones that are non-mint, are the flavor just doesn't last very long. It's usually fruit or bubble gum, so that's the only reason I recommend it. So chewing gum, if you're getting rebounds, you ought to be chewing gum. And by the way, for those of you who are exercising a little more than walking, take an extra belt of Gaviscon or whatever else you know, and suck on gum or chew gum, chew gum or suck on hard candy while you work out, and that'll help. Try to avoid any kind of procedure that increases gastric pressure. Downward facing dog, push-ups, planks, bench press. I've said that before. And that question of limiting exercise and changing exercises is actually number 9 in this program. Finally, I recommend a probiotic. A patient reported to me that reflux got much better when they started a particular probiotic, and then another one came, the same thing, and then I recommended it to some people, and then I started taking it myself, and it did make a difference. I don't have reflux, but I have other issues. It just made the whole GI tract work better. It really has a lot to do probably with gut health. If you read this, I have an article, it's acid reflux and gut health, and that's going to be a really, really important opening field. So the one that I use is Garden of Life, 90 billion. So each of these things are something different. Chewing gum does something very, very different than, high gravity good acid reducer for guanidine, good blocker upper. That's what the alginate does. It goes to the top of the stomach, forms a raft, and helps block up the lower esophageal sphincter. And by the way, most of you have supine nocturnal respiratory reflux. You reflux at night while you sleep, and all your symptoms during the day. You can reflux during the day too, but my experience is most people don't have heartburn or indigestion, but they do have other symptoms. And I'm working on my book, and I wrote out I went late today. I'll keep going. I put out a list of the common symptoms. I was going to talk about the big 5 or the big 4, and it turned out it was the big 20. Here it is. Postnasal drip, hoarseness, asthma, pseudoasthma, choking episodes, shortness of breath, globus, dysphagia, cough, sore throat, snoring, sleep apnea, nasal obstruction, bronchitis, recurrent bronchitis, enlarged uveal, bitter taste, especially in the morning, halitosis, rapidly progressive gum and dental disease in adults, pneumonia, especially recurrent pneumonia, ear pressure popping, pains, and it is heartburn and or indigestion. So I'm going to stop here. I've been covered more material today, and I'd like to answer some of these questions before we, and this is a really important one. This is a complex question. They want to know if esophageal manometry, which measures how well the esophagus works, whether they should have esophageal manometry. Now, I can tell you the primary cause of dysmotility is reflux. I've had patients with no function at all return to complete normal when the reflux gets better. So I'm not a big fan of that. However, there's a zinger in here. She's not the average person. Could this be related to the radiation I had for breast cancer? And the answer is, even though it was a long time ago, you probably are low on bicarbonate, and if you have bad dysmotility, I'll be treated. But if you have reflux, treat that first. And another question about manometry, I'd like to have it after transition. No, you wouldn't. What I tell people is do your detox, 4 weeks, detox program. And then you got to only change one thing at a time. So you change some foods, you let the bed go down, but you got to wait a few days with everything else the same. So it's really a trial and error that takes more than a month. And then if you're still having symptoms, get a barium swallow esophagram, and you want to get it upright, standing, and supine lying down. It's ironic that was the test I started out with before I had ambulatory double probe pH monitoring, but at this time none of these GI tests are useless. The number of questions, all my tests were normal, but I still think I have reflux. You do. And remember, GIs know nothing about respiratory reflux or LPR. I'll do 2 more. Relatively new surgery called reflux stop uses implanted ball to restore the angle. All these, going to help you. Links, magnets. No. There's only one surgery. Surgery is needed, and it's a 360-degree laparoscopic fundoplication. So this idea that these little devices, someone's going to make a lot of money, and then it'll go the way of a lot of crappy treatments. I'll get a less complicated question. There are tons of questions. How do I get off Nexium? How do I get from PPIs? You just go on to a detox program, and you can add gum chewing after every meal, alginate after every meal, and you'll get through it. One more. This whole page was about getting off PPIs. This is the 1 cup a day of coffee, fine. Now, this one I want to address. I'm losing 5 pounds a week on detox diet. Sound normal? No. I'll tell you a funny story. I've told this before on one of these forums. I went vegan, this was a long time ago, and I started gaining weight. And if you read my article on rice, that's the breakfast I had. 650 calories with the fish and the egg. So understand that's about portion control, and if you are prone to losing weight, you may have to have more meals. But you ought to, you need 1,800 calories and 45 grams of protein. I was shocked. Sardines are 26 grams of protein. So anyway, this has been long, a little bit over, more than usual. I'm not sure I discussed all of the mechanisms, but I think you should know that what this program that I'm recommending, and someday it won't be so complicated. We're working on an anti-pepsin drug, which is going to first be a pill, and it's going to be 5 years before we can get aerosolized. But that's what you're going to do. You're going to get a little aerosolizer or put it on next to your bed when you sleep at night, and so it'll go everywhere. It'll be in your lung, it'll be in your nose, it'll be in your throat. And it prevents pepsin from binding and kills pepsin. Now, is that going to be a cure for reflux? No. But it is sure going to make a big difference. So, as we have it, go gently into this good night. I won't go gently.